Hello, everybody. Thank you for joining our virtual education session that's being hosted by GUPS. Today, we are extremely fortunate to be joined by Dr. Argani. As you're all aware, Dr. Argani is a professor of pathology at the Johns Hopkins University School of Medicine, and he also serves as the deputy director of surgical pathology there. He's on the editorial board of numerous scientific journals, including the American Journal of Surgical Pathology, Modern Pathology, the American Journal of Clinical Pathology, and the International Journal of Surgical Pathology. And I'm sure that most of us in the GU community are very familiar with Dr. Argani's body of work. And today he's going to talk to us about one of his many areas of clinical expertise, which is pediatric renal neoplasia. And so if you have any questions for Dr. Argani, please direct these to the QA box at the bottom, and we'll get to it at the end of the talk. So without further ado, I'll turn it over to Dr. Argani.
So thank you, Shonak and Samson. I appreciate the opportunity to speak. And today I'm going to cover, as you said, pediatric renal tumors. I'll cover the four main pediatric tumors that we're most likely to see, and those will be Wilms tumor, clear cell sarcoma of the kidney, congenital mesoblastic nephroma, and rhabdoid tumor of the kidney. I can't be comprehensive in this, but I'll try to focus on areas that I find particularly difficult and some of the differential diagnostic challenges. So we'll start with Wilms tumor. So as we know, Wilms tumor is a tumor of childhood. The mean age is around 3.5 years. The typical presentation we think of as an abdominal mass or hematuria. 5% will be bilateral and 10% multicentric. In those cases, we think of syndromic associations such as Beckwith-Wiedemann syndrome, Wager syndrome, et cetera. Wilms tumor typically metastasizes to the liver, the lymph nodes, and the lung, the three Ls. If there's a metastasis to another site, it actually makes you question the diagnosis. Could this actually not be a Wilms tumor, or could it be a mimicker? And importantly, Wilms tumor is highly curable with modern chemotherapy. So here's a gross of a Wilms tumor. Characteristically, these tumors, as we know, are encapsulated, and they tend to have a multinodular appearance that's variegated, and that reflects the different cell types that we see in these tumors. Histologically, the classic triphasic Wilms tumor, which is seen on the bottom, panel A, essentially recapitulates normal development of the kidney. So if we look at a 20-week gestation autopsy, we'll see what we see at the top with the blastemal cells condensing into tubules, which then get penetrated by blood vessels to make glomeruli in a background of a spindle cell stroma. So similarly, a classic Wilms tumor has blastema, epithelium, and stroma in variable proportions. So the one histologic feature which is prognostic in untreated Wilms tumors, is anaplasia, which we should spend some time on. So this is defined strictly as nucleomegaly with hyperchromasia. And then we also want to see atypical mitoses to be sure that we're not just looking at degenerative nuclear enlargement. Anaplasia is uncommon in the first year of life, and it sort of progressively increases, and it's associated with p53 mutations. So the classic anaplasia is easy to recognize. We're looking for big, large nuclei that are, markedly enlarged compared to our endothelial cells and multipolar mitotic figures. But in my experience, anaplasia is difficult to find in blastemal-rich tumors. And that's because we have all this blue, and even in favorable histology, Wilms tumors have lots of mitotic figures. And picking out these atypical mitotic figures in this background of blue and discerning that these nuclei are really enlarged in a background of these blue cells, I find to be very challenging. So for me, one of the things that helps me is when I'm looking at a Wilms tumor, usually there's some stromal component there. And the first thing my eyes often catch are these big, dark, big nuclei in the background of the pale stroma. So when I screen these slides at around 10x, I'm looking in particular for those sorts of big nuclei in the background of the stroma, and then I focus in on the blastemal cells to see if I see the same changes. One other pitfall that I found is quality of your sections. So this is a thick section of a Wilms tumor, and there's no way I could diagnose this as anaplastic. But if you get a thin section of this exact same block, it looks like this. And here's your atypical mitotic figure. And you can see with a thinner section, the enlargement of these nuclei relative to the endothelial cells. So as I'll say at the end, we usually like these tumors to be fixed overnight so you get adequate fixation so you don't run into this problem. What can help you in this type of a case is immunohistochemistry per P53, though you have to be careful. You want to see a clearly abnormal result, such as this, where you, in the case that I just showed you, where you have diffuse staining of every nucleus. That will support the diagnosis of anaplasia. So the diagnosis, as I said, of triphasic Wilms tumor is usually something that's not very difficult. Where I think it's difficult for me is when you get monophasic Wilms tumors, where you just have one of the component as the sole or the dominant part of the tumor. And each of these, blastemal, stromal, or epithelial, raises a set of differential diagnoses. And I'll start to run through those now. So the first one is the diffuse blastemal Wilms tumor, which is the prototype small round blue cell tumor. And this raises a broad differential, including lymphoma, neuroblastoma, et cetera. These tumors are highly angio-invasive, so they typically present at advanced stage. When we're looking at the kidney, we often see vascular invasion. Here's an arcuate arteriole, and you can see that there's vascular invasion in this case. Blastemal Wilms tumors, because they present at advanced stage, they tend to present at advanced stage. We have to be very careful in terms of staging them, in terms of how we evaluate our sections. So one of the important things to look for is sinus vascular invasion, which bumps us from a stage 1 to a stage 2. And here's a section of the sinus. Often we know the section is from the sinus, so we know to look for vascular invasion there. Of course, it helps to see that there is urothelium. That'll clue us in that we're looking at the sinus. Another thing that's helpful, though, that's helpful for identifying being in the sinus is the fact that the cortex that faces the sinus is unencapsulated. So if you see glomeruli without a capsule facing large blood vessels, you know you're in the sinus without looking at the slide description or having to find the urothelium. And finding plugs of tumor cells in these vessels in the sinus bumps you to a stage 2, sinus vascular invasion. Another important thing is our evaluation of the capsule. So Wilms tumors are typically large and they're encapsulated, so they're under pressure, and they often have a capsule that's very tense. And when we look at the capsule, in many areas, it may seem that it looks intact, but it's very important, in my experience, to look for little areas of thinning and particularly little areas of hemorrhage, because that's where a Wilms tumor, probably because of some trauma which has brought it to attention, may herniate through that thick capsule and lead to a positive margin. So this is one such example. And in this case, the majority of the tumor had this capsule or pseudocapsule separating it from the margin. But there was one little area of weakening and hemorrhage in the capsule. And a section taken from there shows that in this area of hemorrhage, you have tumor involving the margin. And that bumps you to a stage 3 tumor, which could buy the child adriamycin chemotherapy and radiation, whereas they otherwise wouldn't get them. So careful evaluation of the capsule is important. Oops. Let me see if I can advance. For some reason, I can't advance. Let's see if we can fix this here. There we go. The next slide, the other thing that we think of that frequently happens with these blastemal Wilms tumors is lymph node metastases. And lymph node metastases of blastemal Wilms tumors are very tricky because we're looking for these little blue cells in a background of blue cells of lymphocytes. It's almost as bad, I think, as looking for lobular breast cancer. I think you have to look carefully and looking for the differences in the chromatin between the blastemal cells that mold each other and the lymphocytes is the thing that clues you in, and you can do WT1 immunohistochemistry or keratin in difficult cases. So the differential diagnosis of blastemal Wilms tumor includes all the small round blue cell tumors. In the kidney, particularly if bilateral, we think of lymphoma. In a very young child, neuroblastoma. Let me go through two of them in particular. These are Ewing sarcoma and hyperplastic perilobar nephrogenic rest. So primary renal Ewing sarcoma is actually a disease of young adults and teenagers. So the mean age is overall in agree with the literature is around 28 years. These are very aggressive tumors. They're typically large. A third of them present with metastases, a third of them develop metastases, and most of the cases that have been alive without this, alive who have had good overall survival, they've had minimal follow-up. So this is a very aggressive tumor. And some of these cases were previously probably misdiagnosed as adult Wilms tumor, which may be one reason that adult Wilms tumor has a bad name in terms of its prognosis. So here's an example of a primary renal Ewing sarcoma. You can see there's a fleshy tumor with these satellite nodules indicating vascular invasion within the kidney. Histologically, we look for our small round blue cell tumor with our homocyte rosettes, and O13 or CD99 immunohistochemistry is useful in that it's membranous in Ewing sarcoma. Wilms tumors can stain, but usually more of a grungy cytoplasmic stain. The thing I find most helpful is actually just the cytology. So Ewing sarcomas tend to have evenly spaced out nuclei, whereas Wilms tumor blastemal cells tend to mold to each other, similar to what we think of in small cell carcinoma. And I think this makes sense because these cells have desmosomes, so they cluster together more closely, and that to me is a clue that this might be a blastemal Wilms as opposed to a Ewing sarcoma. The second differential I'll talk about is perilobar nephrogenic rests, which when they become hyperplastic can mimic a blastemal Wilms tumor. And this is from the AFIP fascicle. And I just want to call out the two people who we've lost in our community who are two of my favorite people to work with and learn from, and that's John Ebley and Dave Grignon, who are authors on this fascicle. So perilobar nephrogenic rests, as we see in this schematic, tend to occur at the periphery of the renal lobe, and that's because they reflect an insult to developing kidney that's late in gestation. Remember, the lobes develop inside out, so the periphery of the lobe develop later than the medial portions. Perilobar nephrogenic rests tend to have an ovoid shape to them, whereas Wilms tumors are spherical, and they tend to be unencapsulated, whereas Wilms tumors tend to have a capsule. So here's an example of perilobar nephrogenic rests. And perilobar nephrogenic rests, like intralobar rests, have a sort of a lifespan to them. So they may begin as proliferative, but then they may sclerose, or they may develop nodules of proliferation within them. But you can see that here they are lens-shaped, not spherical, and they're unencapsulated adjacent to the native kidney. The problem is with perilobar nephrogenic rests when they're hyperplastic is that if you took a sample from the middle of this area where my arrow is, you might get something like this, which could be a blastemal or a blastemal predominant Wilms tumor, but it could be the middle of a perilobar nephrogenic rest. You can't tell because you can't see the capsule and you don't know the shape. It turns out from this case was from here, which is actually a very hyperplastic nephrogenic rest. You can see no capsule, and you can get the sense that this has this ovoid appearance. But it could easily have come from this, which is, I think, a Wilms tumor with a capsule here arising out of a background of a nephrogenic rest. Note the spherical shape of this, at least in 2 dimensions, it looks circular, and the capsule. So what do you do if you get a little biopsy that just has the proliferating cells? I call those active nephroblastic proliferation and say that I can't tell which one it is. Usually it's not a problem because if they're doing a needle biopsy of one of these lesions, it's large, and either way, if it's hyperplastic rest or Wilms tumor, the treatment is usually chemotherapy up front, so it's not a big deal. So that's my terminology, active nephroblastic proliferation. Now, moving to stromal predominant Wilms tumors, one of the things that's very helpful, I think, in looking at any kind of pediatric renal tumor is that if you see skeletal muscle, it's a very good sign of seeing it being a Wilms tumor. I've seen only a handful of rhabdomyosarcomas in 25 years of looking at these tumors. So seeing true skeletal muscle differentiation, you're pretty sure it's going to be a Wilms tumor. You just have to look for other elements. The main differentials, I mentioned rhabdomyosarcoma is uncommon, are I think synovial sarcoma and intralobar nephrogenic rest. So renal synovial sarcoma, similar to Ewing sarcoma, tends to be more of a disease of young adults. The median in overall review of the literature is around 43 years. They tend to be large tumors, often cystic. They're advanced at presentation and have a poor outcome. And again, they probably have been mixed in with some tumors that were previously called adult Wilms tumor, which is another reason adult Wilms tumors have a bad name. This is the outcome on a review of the literature. 50% either have metastases or died, and those with no evidence of disease had very minimal follow-up. So this is an aggressive tumor. So we're all used to diagnosing synovial sarcoma, which presents as a lesion in the arm, for example, of a young adult, where you get these intersecting fascicles of plump spindle cells. In the kidney, we sometimes get into trouble because we get that monophasic synovial sarcoma appearance, except it tends to entrap native renal tubules. And that gives an appearance that sort of resembles a cystic nephroma. So some of these cases were probably previously characterized as sarcoma arising in cystic nephroma. Here's some of the hypocellular areas where the native renal tubules get entrapped and cystified. And sometimes in the cysts, the collecting duct epithelium can actually be hyperplastic, and you can get these cells popping off into the fluid of the cyst. So you always want to be careful when you get FNAs of cystic renal lesions, and make sure you're not dealing with the collecting duct epithelium in a cystic tumor and not diagnose that as a renal cell carcinoma. These tumors, synovial sarcomas, are often cytokeratin negative in the kidney. You'll just get the native renal tubule staining. And in the kidney, they often turn out to be monophasic spindle cell tumors. So the majority in the kidney are monophasic, which correlates with having the SSX2 fusion, whereas the opposite is true in soft tissue, where it's more likely to be biphasic and SSX1 associated. It kind of makes me wonder, are we missing some biphasic synovial sarcomas in the kidney, and maybe we're still calling some of those Wilms tumor? Or maybe this is a real predisposition. I'm not really sure at this point. Now for intralobar nephrogenic rests. So these reflect an earlier insult to renal development. So they tend to occur in the central portions of the lobe, or actually sometimes even in the renal sinus. And you can see that they tend to have a more irregular border to them. So when we distinguish those from Wilms tumor, the main differential distinction is the infiltrative nature of their border, as well as the fact that they tend to have lower cellularity than a stromal Wilms tumor. So here's one such example of an intralobar rest. So it will have all the elements of a Wilms tumor, but you can see there's a stromal predominance. It permeates amongst the native nephrons out here. Again, Wilms tumors are typically encapsulated. And you notice that you see fat actually out here. Fat is very common in intralobar rests. It's actually uncommon in Wilms tumors, whereas skeletal muscle is the opposite, common in Wilms tumor, less common in nephrogenic intralobar rests. Here's another example of an intralobar rest. You might think that this is just permeative blastema, but you notice that there's a stromal component here that's encircling the native renal tubules. This would be part of a hyperplastic intralobar rest. The best place to see intralobar rests is at the periphery of your Wilms tumor. So this is the gross of a Wilms tumor. I apologize, the central portion isn't very well fixed, but you can see you have your nice Wilms tumor with its capsule, but you see also these little lens-shaped areas at the edge that permeate or that are intermingling with native kidney. Those are the intralobar nephrogenic rests. It's kind of like the orange peel around the orange. So when you look histologically, here's the Wilms tumor, here's the capsule, and here's the nephrogenic rest permeating amongst the native renal tubules. So that's why we take sections at the periphery of the Wilms tumor to identify intralobar rests. So for epithelial Wilms tumor, we have our differential. I mentioned perilobar rests, and I'll go through the rest of these. So Ewing sarcoma, I want to briefly mention that one thing that is not always remembered is that when renal tubules form in a Wilms tumor, they go through a stage that actually looks very much like a Homer-Wright rosette, where you don't have the lumen. And if you just look here, you might think, oh yeah, this is a Ewing sarcoma. This is a stage in development. When you find other areas where you have well-formed tubules like this with lumen, you know this is actually an epithelial tumor, and it's a Wilms tumor. So Wilms versus papillary renal cell carcinoma is mainly a problem, I think, in older patients, where the differential is the so-called type 1 papillary renal cell carcinoma. In general, papillary renal cell typically has more open chromatin, more diffuse staining for cytokeratin 7, and is negative for WT1. So here's one such example of a solid variant of papillary renal cell carcinoma. You can see the foam cells over here, over to the left. And these tumors typically labeled diffusely for CK7, whereas Wilms tumors are typically more patchy. Again, and this would be negative WT1. Metanephric adenoma is another differential diagnosis. So metanephric adenoma, unlike Wilms tumors, usually unencapsulated. The cells tend to be cuboidal and lack mitotic activity. And we now know that metanephric adenomas are associated with BRAF mutations, whereas Wilms tumors typically not. So I always think of metanephric adenoma as something that looks like a differentiated epithelial Wilms tumor. So you can see here it's unencapsulated with the native kidney. And then when we look at the cells, they're cuboidal, they're not columnar, not a lot of mitotic activity. Now, in the past 10 years or so, it's been shown that metanephric adenomas are consistently associated, or in the majority of cases, with BRAF mutations, whereas Wilms tumors in large sequencing studies are not, which suggests that they are completely different. But that is not entirely true. This is work done by Sarah Wabker when she was here as a fellow here at Hopkins, and she's expanded on this. It seems that there's a distinctive subset of Wilms tumors that have BRAF mutations. These occur in both children and adults. They tend to be epithelial predominant Wilms tumors that have areas that look like metanephric adenoma. And importantly, the one case that we had and another case reported in the literature have responded to targeted therapy using BRAF MEK inhibition. So this could have therapeutic implications. This is one of the cases that we had at Hopkins that I'll mention. So this was in the upper left panel. You can see that this is a Wilms tumor with a capsule, and the panel to below where my arrow is shows the typical morphology of a Wilms tumor with epithelial, columnar nuclei, even a stromal component. Looks like a typical Wilms tumor. Though you'll notice off to the side here, there's this hyalinized area, and those areas had more of a metanephric adenoma-like appearance. So this was actually a stage 1 Wilms tumor, and you expect a very good outcome for those patients. But surprisingly, this tumor showed up as a lung metastasis, I believe 3 years later, which was very upsetting to the parents and the whole clinical team. Most stage 1 Wilms tumors do very well, over 98% survival. Well, this tumor was sequenced and shown to have a BRAF mutation, and that led us to study these Wilms tumors with metanephric adenoma-like areas and show that they often have these have BRAF mutations. So we furthered this because the initial study we did included adult and pediatric cases. We thought maybe there might be a predisposition for adult Wilms tumors to have BRAF mutations. And this is work with many people who are probably on this part of the groups or maybe on this call. And this is work with Doreen Palsgrove, who's now at UT Southwestern. We looked at a series of adult Wilms tumors. And what we found was that most adult Wilms tumors actually have the same genetic alterations that you see in the pediatric counterpart in terms of WT1 mutations, etc. But a quarter of them have BRAF mutations, and all of those cases have metanephric adenoma-like areas to them. And in several of the cases, they had areas within them where you could clearly delineate the Wilms area from the metanephric adenoma-like area. And because of this, we were able to selectively sequence different parts of this tumor. And what we found was when we would look at the metanephric adenoma area, we would just find the BRAF mutation. But when you looked at the Wilms tumor area, it had not only the BRAF, but other alterations, including TERT and this other gene, which is implicated in Wilms tumor. And I think that suggests, along with just this morphology, that the Wilms tumor is arising out of the metanephric adenoma. It even looks like it, I think grossly, it looks like there's a clone here arising out of the metanephric adenoma. So I think traditionally, when we talked about a relationship between Wilms and metanephric adenoma, we've always thought of that maybe the Wilms tumor is differentiating into the metanephric adenoma. But I think based on the morphology and the genetics, I think that some metanephric adenomas can give rise to epithelial predominant Wilms tumor. And that, I think, has some implications to how we follow patients with those. Is it safe to leave them in if they've had a core biopsy, for example? Another area that I think there's been some change in is in the cystic Wilms tumors related lesions. And historically, we've thought of these as pediatric cystic nephroma, cystic partially differentiated nephroblastoma, and cystic Wilms tumors. And we've always thought of these as part of a spectrum. So let's run through those. So we think of a pediatric cystic nephroma as an entirely cystic lesion with no primitive elements in it, just a fibroblastic stroma with some entrapped tubules. Cystic partially differentiated nephroblastoma, and this is a beautiful slide that was loaned to me by Gordon Rhabdoid, is very similar in that it's grossly completely cystic, but when we look carefully, we find little nodules of primitive nephroblastic elements that do not distend the septa. So as Dr. Beckwith used to say, the cysts will mold the septa do not mold the cysts. So it's very much analogous to what we see in clear cell neoplasia in the kidney, where we talk about multilocular renal cell neoplasm of low malignant potential, where we just have clear cells in the septa, but no expansile nodules. In contrast, a cystic Wilms tumor may look in many areas like a cystic partially differentiated nephroblastoma or cystic nephroma, and to our radiologists and even to us, but finding a solid nodule of primitive elements such as this makes this a cystic Wilms tumor. So this tumor had many areas that could have qualified as cystic partially differentiated nephroblastoma, but that solid area had this primitive look. So that's a cystic Wilms tumor, similar to what we would call in clear cell neoplasia, a cystic clear cell RCC. So I think one of the first persons who delineated that there are differences between pediatric cystic nephroma and adult cystic nephroma was, again, John Ebley. I think around 1995, he wrote a very nice paper on this subject. And I think this has been borne out. So we know of pediatric cystic nephroma as typically young patients, adult cystic nephroma as adult, or typically in adult females, whereas there's an even split in gender here among the pediatric cases. We now think of the adult cystic nephromas as part of the MEST spectrum, mixed epithelial stromal spectrum of Wilms tumors. We had thought of pediatric cystic nephroma as part of this spectrum of cystic partially differentiated nephroblastoma, but I'll say I don't think that probably is not true. But the distinction between pediatric and adult cystic nephroma, I think, is borne out by the fact that the pediatric cases are associated with dicer mutations, whereas the adult cases typically are not. So we know from multiple studies that dicer mutations, which are seen in pediatric cystic nephromas, are generally absent in adult cystic nephroma. But one thing that was surprising is that the dicer mutations are not seen in cystic partially differentiated nephroblastoma. And if that's part of the spectrum of cystic nephroma, you might expect that they would. So that argues that this historical view that we've had of pediatric cystic nephroma being in the spectrum of cystic partially differentiated nephroblastoma is not true. And in fact, really, based on, this is going back to this 2016 WHO and included in the 2022, we now think of pediatric cystic nephroma as a distinct entity associated with dicer mutations, which can progress to a anaplastic sarcoma of the kidney, whereas adult cystic nephroma is different. It's part of the MEST family of tumors. And there are some morphologic differences, I think, between adult cystic nephroma or MEST and pediatric cystic nephroma. Adult cystic nephroma or MEST, even when very cystic, will have this sort of wiry collagen ovarian type, more ovarian type stroma, and it will stain with inhibin in addition to ER, whereas pediatric cystic nephromas don't have that collagen. They will stain with ER because they're cystic lesions, as Satish Tuku has shown us, but they tend to not stain with inhibin. Okay, so let's now move on to clear cell sarcoma of the kidney. So this is typically one of the tumors that causes most of the diagnostic problems in the field. So typical age is 2 years. There's a 2-to-1 male to female predominance. It's a tumor that tends to metastasize to unusual places like bone. But actually now with modern chemotherapy being more effective, the brain metastases actually are starting to outnumber bone metastases because the brain is protected from the chemotherapy. So it's sort of a sheltered site where the tumor can spread. As I mentioned, modern chemotherapy has improved the prognosis. This tumor, though, can recur late. Wilms tumors usually will come back within 2 years of diagnosis. Cystic clear cell sarcoma of the kidney can show up 10 years later and show up in unusual sites. So here's the gross of a CCSK, and many people who describe these grossly note that these look like brains, so they're often described as encephaloid lesions. And here's the characteristic histology where we have this very uniform branching spindle cell, chicken wire vasculature, and with associated cells lining these septa. And then the what are called the cord cells, which are these cells that have very open chromatin and very minimal pink cytoplasm and are surrounded by extracellular mucopolysaccharide material. So the name clear cell is actually wrong. These cells have very little pink cytoplasm, but they secrete mucopolysaccharide, and that's why they look like they're clear. Here's sometimes the mucopolysaccharide becomes more prominent, so you get these sort of microcysts of this mucinous material, and sometimes the septa become hyperplastic. We used to think that these were neoplastic cells. I'll show you based on immunostaining. I think these probably are not. They're probably just supporting cells, but we'll get to that in a second. CCSKs look like they're well delineated, but they often entrap native renal tubules at their periphery. And some of these can undergo what's called embryonal hyperplasia. So they get this blue cell appearance, and that can cause a problem with the diagnosis, the differential diagnosis of Wilms tumor. So CCSK causes problems because it has many morphologic variants. And I'll show what some of these variants are. So here's one that's more cellular. It can raise the differential of a Wilms or a Ewing sarcoma. Here's one that looks very epithelial. It almost looks like it's making tubules. These even areas like this will be cytokeratin negative, which is distinguished it from Wilms tumor, can have a very trabecular pattern, almost look like a carcinoid tumor. They can have this hyalinization. So some of them in the old days were called renal osteosarcomas, or the differential of a sclerosing epithelial fibrosarcoma comes up. They can be spindled like a synovial sarcoma. They can have a DFSP-like storiform pattern. They can have palisading like a schwannoma does. They can even have anaplasia like you see in Wilms tumor, only about 3%, but it can happen as a superimposed problem. So there's a broad differential of CCSK depending upon the pattern that it tends to show. I'll show some other examples of problems associated with the diagnosis of CCSK. This looks a lot like the CCSK that I just showed you. But one thing to remember is poorly fixed blastema in a Wilms tumor can have very open chromatin. So if you back off of this, you'll see that this is actually blastema as part of a biphasic Wilms tumor. So again, the importance of fixation of these lesions. And this is just showing it at high power. Poorly fixed nuclei often have this watered out appearance. This looks very much like it could be a Wilms tumor. You see very florid blue cells here with a spindle cell component. This is a core biopsy. You could easily think of this as a Wilms tumor. One clue, I think, is that there's a lot of this hyalinization in the background here. That's uncommon in an untreated Wilms tumor. This turns out to be a case of a CCSK with very florid embryonal hyperplasia. So here are the CCSK cells with this nice open chromatin, and this is very florid embryonal hyperplasia of entrapped native renal tubules. Here's a lesion that was in a patient 10 years after their kidney resection involving the skeletal muscle of the chest, and this was thought to be a fibromatosis, and it certainly looks like it could be. It's permeating skeletal muscle as this bland spindle cell pattern with the big prominent vessels, but this child had a history of a CCSK, and further sampling of this tumor showed more areas more typical of a CCSK. So Dr. Beckwith used to always say that any lump in a child with a history of CCSK is metastatic CCSK until proven otherwise, because these can go to unusual sites and have unusual morphology. So what helps us diagnostically? Well, all these patterns I think are difficult, but seeing a combination of patterns in one tumor helps. Negativity for most of the immunomarkers that would support other things in the differential diagnosis, CD99, cytokeratin, S100, CD34, and then finally that fine chromatin and regular capillary vasculature that I think is the hallmark of this neoplasm. Well, in the last 10, 15 years, the genetics of CCSK has been unraveled. So most CCSKs are associated with internal tandem duplication of the B core gene. Some of them are associated with the same gene fusion that we see in high-grade endometrial stromal sarcoma, the 1017 translocation. And then a small subset have the B core CCNB3 fusion that we more commonly associate with soft tissue and bony tumors. Regardless of the genetics, though, all of these tumors overexpress B core. So B core immunohistochemistry can be very useful in the diagnosis of CCSK. We have to be careful because Lots of tumors can have patchy staining. It's when we get this very diffuse staining of over 90% of the nuclei and the background renal tubules that are entrapped or negative. That I think is good evidence to support the diagnosis of CCSK, though we have to be careful. Some of the things in the differential solitary fibrous tumor and synovial sarcoma can stain with BCOR, so we have to use it cautiously. One thing other that's also helpful is the BCOR stains these cells that are the cord cells, but not the hyperplastic septal cells. So I think that argues that the septal cells are probably not neoplastic in these lesions. Next tumor we'll talk about, the third, is congenital mesoblastic nephroma, or CMN. It's the most common congenital renal neoplasm. Almost never occurs above the age of 30 months. It's essentially a low-grade fibroblastic sarcoma, and it's usually cured by excision. It mainly recurs locally and rarely metastasizes. So this is a tumor that has this historic name, and it was originally described as the classic CMN, but that's only 24% of cases. Most of the cases are cellular, a minority are mixed. So the classic congenital mesoblastic nephroma is basically a fibromatosis of the renal sinus. So you get these broad fascicles of bland spindle cells which intersect and dissects apart islands of native nephrons, as opposed to the single nephrons that are permeated by a CCSK. And the cells are typically bland, not a lot of mitotic activity, a decent amount of collagen production. In contrast, the cellular CMN is a fleshy, large tumor that pushes aside the native kidney. So here's one such example. It has a lot of hemorrhage, and you can see its border with the native kidney tends to be pushing. Morphologically, this looks like a high-grade tumor and looks a lot like, and is in fact genetically identical to, an infantile fibrosarcoma. It looks certainly high-grade. These often have large areas of necrosis, lots of mitotic activity. Even here, palisaded necrosis almost reminds you of a glioblastoma. But these turn out to be low-grade neoplasms despite this ominous appearance. And then there are the mixed CMNs, where you get areas that look cellular, as I see to the left, and then more classic to the right. So the distinction of these tumors is I think mainly can be made on morphologic grounds. Classics tend to be infiltrative, cellulars are pushing. Classics tend to have a low mitotic rate versus the high in the cellular. Necrosis is rare in the classic, common in the cellular. And I think the genetics has really sorted this out. So the cellular CMN, which is essentially an infantile fibrosarcoma of the renal sinus, characteristically has the ETV6 NTRK fusion that you also see in infantile fibrosarcoma, whereas that's typically absent in classic CMN, whereas internal tandem duplication of the EGFR is present in most classic CMNs, and it's usually absent in the cellular CMNs. So when I think of these infantile fibroblastic tumors, I think of infantile fibromatosis as really analogous to classic CMN. The cellular CMN is essentially identical to infantile fibrosarcoma. And the mixed CMNs, I think, correlate with what the soft tissue pediatric pathologists consider composite fibromatoses, tumors that have mixed morphologic features of classic and cellular. And most of those lack the ETV6 NTRK3 fusion. They tend to be associated with the EGFR internal tandem duplication. I should say that the molecular spectrum of cellular CMN has expanded, similar to what's happened with infantile fibrosarcoma and soft tissue. So we now have variant fusions, and there are other fusions which feed into the same pathway, such as RET, MET, ALK, and even BRAF, that can be associated with tumors with morphology that overlaps CMN. So this seems to be expanding, similar to the situation that we have in soft tissue. All right, the last tumor I'll go over is the rhabdoid tumor of the kidney. This is a tumor that we see typically in infants. 80% of cases will be in patients less than 2 years of age. A third of these cases are familial, and those tend to be associated with germline INI1 mutations. 15% of patients will have a separate CNS atypical teratoid rhabdoid tumor. And these tend to be the patients who have the germline INI1 alteration. And then these turn out to be independent tumors. So they start out with the germline alteration, but they get separate hits to make these two independent tumors. The name rhabdoid tumor is historic because these cells resemble rhabdomyoblasts, but these are not rhabdomyosarcomas, as we know. These tend to be very invasive in their growth pattern and present at high stage. And we know that these are highly lethal tumors. There's about an 80% mortality at over 2 years. And unfortunately, many of the advances in Wilms tumor and CSK, for example, and in CMN have not really translated to rhabdoid tumor. This is still the tumor where there's an unmet need for good treatment. Genetically, we know that these tumors are typically associated with homozygous inactivation of INI1 or SMARCB1. So loss of INI1 protein by immunohistochemistry is one of the most useful tests that we have. Historically, if you go back in the literature, rhabdoid tumors were associated with chromosome 22q monosomy, and that was, I think, the clue that we were dealing with an INI1 associated tumor. A small subset of these cases will have BRG1 or SMARCA4 inactivation. So here's the growth of a rhabdoid tumor, typically a fleshy tumor, often a permeative border. You can see it seems to be protruding here into the native kidney. It's very uncommon for these tumors to decline the chance to invade a blood vessel when they see one. So typically advanced stage tumors and a very aggressive growth pattern. You can see this is a sea of these neoplastic cells. And here's a glomeruli a glomerulus that's been overrun by this tumor. This kind of sheet-like pattern is not something that you typically see in CMN or CCSK. You might see it in a blastemal Wilms tumor. It's the kind of pattern you really associate with lymphoma in the kidney. Very aggressive growth pattern. And then we look at the cytology where we want to see the classic 3 features of rhabdoid cells. So we want to have open vesicular chromatin, very prominent nucleoli, and this hyaline cytoplasmic inclusion, the classic morphology that we look for. This is probably one of the better examples of rhabdoid tumor I've ever seen in my career. Really shows great rhabdoid morphology. But like all of these tumors, the tumors can have variant morphology that we have to look out for. So some of these tumors have a very sclerosing appearance to them. You can see that this one still has the rhabdoid cytology to it, but a very sclerosed appearance to it. These tumors can have spindle cell areas, and particularly in a young child, the differential of a rhabdoid tumor and a cellular CMN can be very difficult, and they have overlap, and they have tremendous difference in prognosis, even though they both can look histologically quite scary. Rhabdoid tumors can be spindled like this. Usually with good sampling, you'll find other areas where you find better cytology, rhabdoid cells, and then we can rely on our ancillary tests to help us out. So loss of INI1 is particularly helpful here in supporting the diagnosis of rhabdoid tumor. It should be intact in cellular CMNs, which would typically have the ETV6 NTRK3 fusion. So another important thing to remember is that many tumors can have rhabdoid features. We all know that outside of the kidney, things like melanoma is like classic for having rhabdoid features, epithelial sarcoma. In the kidney, the same thing. So Wilms tumors can have areas with note that renal medullary carcinoma and epithelial sarcoma are also associated with INI1 inactivation. So they not only share the morphology, but they share at least some of the underlying genetics. And this is just a case that was particularly striking. This was a frozen section that we saw, and I think we were thinking potentially that this, could is a small round blue cell tumor, and in this area, it sure looks rhabdoid to me. The clue in this case was that this was a young adult, and this turned out to be an EWS-FLI1 positive Ewing sarcoma, but just showing how these tumors can have rhabdoid features to them. So what are the clues to the diagnosis? Typically young age, we think of less than 5. Above that, we have to be very suspicious of a wrong diagnosis. Typically high stage. We like to see that monomorphic appearance, that classic triad of histologic features in a well-sampled tumor. And by immunohistochemistry, we now rely a lot on loss of INI1 expression. Before we had INI1, one of the things I think is that historically we've used is seeing focally strong EMA and cytokeratin expression. So focal but convincing staining in in neoplastic cells is a feature that goes with rhabdoid tumor. The other tumor that I mentioned that frequently has the rhabdoid morphology that we know is the renal medullary carcinoma. So as we know, this typically affects children and young adults. Almost all the patients will have sickle cell trait or some hemoglobinopathy. These are highly invasive tumors with often a yolk sac-like appearance and a desmosplastic stroma with prominent neutrophils and often rhabdoid cytology. We know that these are very aggressive tumors, and they show loss of INI1 expression similar to rhabdoid tumor of the kidney. But as my friends at Memorial have shown, the mechanism of inactivation of INI1 seems to be different in these two tumors. So here's one gross of a renal medullary carcinoma. Again, a very aggressive tumor. You can see the satellite nodule here with some vascular invasion, very aggressive, blowing out through the capsule. And here's the classic morphology where we have this edematous stroma with neutrophils, and it looks sort of like a high-grade collecting duct carcinoma, high-grade glandular tumor. And then you can see here areas of very rhabdoid morphology in this tumor. One just brief story I should mention is that if you look back at Dr. Beckwith's original study of rhabdoid tumor of children, this is from 1989 with Doug Weeks. If you looked at the table of those cases, there were rhabdoid tumors, and almost all of them were in patients less than 5 years of age. But there were a few outliers that were in patients above the age of 5. That paper was published in 1989. In 1995, two groups, including the AFIP and the group in Boston, described renal medullary carcinomas, which have often rhabdoid features. And when Dr. Beckwith read that paper, he went back to those 3 cases, those outliers from his original study, and he looked at the surrounding tissue. He found this. He found sickled cells. And that just highlights how rhabdoid tumors can really renal medullary carcinomas can really overlap with rhabdoid tumors that have rhabdoid morphology. So just to summarize, I've gone through the major types of pediatric renal tumor. I just want to highlight the importance of the workup in the gross room. So we want to, when we get any type of pediatric renal tumor, the first thing we do is we weigh the specimen. Some of the tumors that are very small may be eligible for no chemotherapy or low chemotherapy protocols. Take the vascular margins. Then I ink the specimen, let the ink dry, and then bivalve it. And then I take frozen tissue of tumor and normal. We need that as a comparison. That's important for LOH studies, where if the tumor has LOH, it might be put in a higher risk category, if not lower risk category. At that point, I usually like to, since I'm freezing tumor for the tumor bank, I usually like to do an unofficial frozen or a touch prep and see what it looks like. If it looks like a regular Wilms tumor, I'm done. But if it's something unusual, I might put something up for cytogenetics. It might turn out to be something unusual. Then I would fix the specimen overnight after cutting it into 1 centimeter slices. I've shown you how anaplasia can be missed in poorly fixed sections. It's well worth your time to let this thing fix properly to get good sections. And then we want to map your sections on pictures of the slices. So this is from the fascicle showing a map of sections. And I always say, don't take a lot of sections from here. Take one, and that's all you need. Most of the sections should show relationships. So you want to see the tumor to the capsule. You want to see the tumor to the capsular margin, because that could bump you up to a stage 3. You want to see the relation of the tumor to the native kidney. That could help you find intralobar nephrogenic rest and get a sense of how aggressive the tumor is. You want to take sections showing the sinus, so sections pointing toward the sinus, and just sections of the sinus to look for vascular invasion. And then you also want to take just some background normal kidney sections. That's where you might find your perilobar nephrogenic rests. So good sampling, I think, helps us tremendously in the diagnosis of these tumors. So that's all I have. These are pictures of my kids and my cats. I don't travel a lot now these days, mainly because of these guys. But I like to thank the GUPS for allowing me to give a talk by Zoom, and I'm always happy to do these. And thank you again for the opportunity.
Thank you, Dr. Argani. That was a great talk, and I see that there's a lot of questions in the QA, and I'll start off with one from Dr. Laila Farid, and I think she kind of hits on a problem that all of us have, yeah, and you touched on this earlier, is in differentiating nephrogenic rests and how, on a biopsy specimen, for instance, and how to report those. So if you could summarize that again, I think that would be very helpful to Dr. Farid.
Okay, sure. Yeah, so I often can't make that distinction. So the terminology I use is active nephroblastic proliferation. And I just say I can't tell if it's a hyperplastic rest or a Wilms tumor. The good thing is for us, the reason it's not a problem for us is if it's a Wilms tumor and they're doing a core biopsy, they want to give chemotherapy. And if it turned out to be a nephrogenic rest forming a mass, you want to give chemotherapy because you want to shrink the rest because it's compressing the kidney and messing up renal function. Also, you're getting rid of precursors to Wilms tumor. So it doesn't make a difference clinically. So I use active nephroblastic proliferation.
So also I see a question from Dr. Firoz Tamboli. He says, thanks for the excellent talk. And do you perform any routine immunostains, P53 or BRAF, and or molecular testing on Wilms tumor and or other pediatric kidney tumors?
So we typically will not for a Wilms tumor. I think it's an H&E diagnosis. I only showed I don't do P53 to look for anaplasia blindly. I only showed it in that case because it was a subtle case and the original slides were very poorly fixed. So I don't do that. If I thought it was one of these BRAF mutated tumors, I might do the BRAF immunostaining, so we would do it in that scenario. Um, for CCSK, again, I think it's an H&E diagnosis with a good B core immunostain can support the diagnosis too. For mesoblastic nephroma, I think that's it's more, I think most sarcoma clinicians would want fusions if you can find them. So I think it's an H&E diagnosis, but if we think it's the cellular type in particular, might send it for the fusion, especially because you could now target it with larotrectinib. And then for rhabdoid tumor, the INI1 stain is so good that I don't feel like we need to do molecular on those. So I typically don't.
Uh, I know you mentioned that it's more of a histologic diagnosis for Wilms tumor for you, but on a related note, Dr. Tretiakova asks, would you recommend any particular clone of WT1 if you were to use it?
I don't have, so first of all, I don't typically use WT1 in a conventional Wilms tumor because it can be negative. I don't have great experience with the different clones, so I can't give you a really educated answer on that. So I'm sorry.
And there's another question regarding post-chemotherapy pediatric Wilms tumors. Could you comment on the morphologic spectrum or any pitfalls in that type of a scenario?
Yeah, so I should mention that in the United States, most Wilms tumors are treated and using the prior NWS current COG protocols are untreated Wilms tumors. So we get to see untreated Wilms tumors. For treated in Europe and in many other countries, Wilms tumors are treated upfront with chemotherapy. So I think the protocol is similar. There are some differences in staging, which are kind of a little bit of minutia, and I always honestly look those up. The one thing is the amount of blastema matters. So in untreated Wilms tumor, the amount of blastema is not independently prognostic because it tends to correlate with high stage, but they're more responsive to chemotherapy. So it's kind of a wash. If you're dealing with a treated Wilms tumor, and you still have proliferating blastema, that's a bad prognostic sign. So you have to quantitate the amount of proliferating of active blastema. And if you have above 2/3, that there are different categories for that, but that can put you into an unfavorable category based upon the amount of active blastema that you see. So that's the main difference.
So there's a question from Kevin Coate, and this kind of gets to your last slide talking about grossing the specimen. And so his question is about, can you expand a little bit on your favored way to prep a large renal tumor nephrectomy specimen for grossing? Would you have any tips for maybe a really large specimen?
Yeah, so it's a good question because I think so many problems happen in grossing that can be corrected. I like to take the vascular margins and ureteral margins first. I learned that from doing testicular cases. I think it's the same story. You don't want to get contamination. I take time inking them and let the ink dry. And that means you can sit for, 15 minutes or so. I'd like to blot it dry, make sure it's nicely fixed. Then I do my section, my initial bivalve section, and that's where I'll harvest tissue. And then I absolutely believe in I make those sections parallel, and I let them fix overnight. No matter what, the clinicians, I mean, you don't need, people are under the mistaken impression that they need this right away. The overnight fixation is the key to is really key. You want very good fixation. So what I do often is I let it fix overnight, and then after I take sections and they've processed the blocks in my histology lab, then I kind of go in the histology lab and I kind of call in a favor if they'll do me one. I try to ask them to cut that case first. I don't want to mess at all with the processing. I want very nice sections. But to expedite the case so that we can meet the needs of the pediatric oncologist, I just ask them to cut that first that day so that the slides come out early. And then usually I have my slides before the pediatric oncologists are calling me, which is nice. Beyond that, just focusing on areas of weakness in the capsule, I think is very good. It almost looks like, it reminds me sometimes of like a tire, a bicycle tire where it's like has a blowout, or a basketball, like where there's like a herniation in it. That's the area I like to focus on for the margin, or capsular invasion.
I think Dr. Rajal Shah has his hand raised, and I think you're probably able to ask your question directly. Dr. Shah, do you want to ask your question? I think you're on mute, Dr. Shah.
Sorry, I think I did not have question, but I just wanted to congratulate. I think it was a very great presentation, and a big thank you from the GUPS leadership.
Thank you very much. I appreciate it.
So I think in the interest of time, we'll take one last question. And I'm just going to pick on one from Dr. Tamboli. He says, any thoughts on pediatric tumors in the renal sinus without any renal involvement that some people regard as extrarenal renal tumors?
So extrarenal tumors, I think I've seen them, and we kind of wonder if these could be, derived instead of the metanephric kidney from the mesonephric kidney. I always think about the possibility of a teratoma, particularly if I'm medial and I'm thinking about, probably potentially, metastasis from a testicular lesion or a retroperitoneal lesion. Fortunately, they're uncommon. I think sometimes just multiple sections to try to see if you can see if it hooks up to the kidney is helpful. But I have seen them; they do happen. Fortunately, they're uncommon, and we do see intralobar nephrogenic rests in the renal sinus. So maybe it shouldn't be that unexpected that we get some medially outside the kidney. So that's the best answer I can give.
Thank you, Dr. Argani. I think we are almost at the top of the hour. This has been very educational, and I just want to let everybody know that this will be posted on the GUPS website. So if you want to refer to this talk again, and if you have any unanswered questions, please direct them our way and we'll forward them on to Dr. Argani. Thank you again, Dr. Argani.
Thank you. My pleasure. Thank you all.
Thanks. Bye, everybody.